Here is a case of a very severe thrombocytopenia in a young child. Platelet count was just 5,000. Imagine that. And on examination of cell counter, we find that immature platelet fraction is very high, that is 50%. So, what are the causes of thrombocytopenia? In which situations you get high immature platelet fraction? What are the bone marrow findings in such situations? Basically, if you want to investigate thrombocytopenia, you want to tell whether thrombocytopenia is because of peripheral destruction or there is some problem in the bone marrow production of platelets. One important thing before all this is that you have to rule out whether thrombocytopenia is artifactual, and that can be done by examination of peripheral blood smear to rule out any platelet clumping or any platelet satellitism. And in such situations, we can examine the blood in the citrate or in heparin tube. Then broadly, once we have categorized the thrombocytopenia, immature platelet fraction helps us in some ways. How it helps? Immature platelet fraction, when it is very high, it indicates that bone marrow is actively producing platelets. That means there is no problem in the megakaryocyte function. Megakaryocytes are functioning normally, marrow is functioning normally. Then why the platelets are low? The cause, of course, has to be peripheral destruction or sequestration in some organs like spleen, if there is splenomegaly. In general, what is the approach to thrombocytopenia? You can do something like this, and in this, what we can see is that once we have ruled out pseudothrombocytopenia based on peripheral smear, you check the RBCs on the peripheral smear. If there are some schistocytes in the RBCs, we can think of microangiopathic hemolytic anemia or disseminated intravascular coagulation. For MAHA, we can look at whether the indirect bilirubin is high. For DIC, we can look at the coagulation screen and check whether there are any abnormalities. If thrombocytopenia is associated with thrombosis in some veins or something, then we have to think of heparin-induced thrombocytopenia, rule out history of any heparin administration. We can also check for catastrophic antiphospholipid syndrome by doing appropriate investigations. If we have neutrophilia, immature granulocytes, toxic granules, think of sepsis as a cause of thrombocytopenia. Send cultures, do procalcitonin, and investigate accordingly. If peripheral blood smear reveals blast, then of course the diagnosis goes towards acute leukemia, which can be investigated with flow cytometry and bone marrow examination. If none of these findings are there, it's just the isolated thrombocytopenia without any apparent cause, then we have to think of immune destruction of platelet, that is immune thrombocytopenic purpura. 80% of these ITPs are primary without any cause, they are idiopathic. But in 20% of the cases, we can find the cause by doing hepatitis serologies, by doing antinuclear antibody testing, by investigating for any drug histories. These are some of the causes in which there is secondary ITP. So, this is the proper approach for immune thrombocytopenic purpura. Then, let us see what is happening in the bone marrow. If you look at bone marrow, the particles are very hypercellular. The marrow itself is cellular. It is trilineage hematopoiesis. All the three elements are seen. RBC precursors are functioning normally, WBC precursors are functioning normally, there is maturation, there are no increased blasts on the peripheral blood smear, and if you examine the marrow fragments, they are very hypercellular and they are showing lots of megakaryocytes. 4, 5, 6 megakaryocytes per fragments, they are there. So it indicates very florid megakaryocytic hyperplasia. Megakaryocytes are going in overdrive, trying to produce more and more platelets, trying to compensate for the peripheral destruction by some mechanism, most likely immune mechanism in this particular case. So in nutshell, this case presented with severe thrombocytopenia, high immature platelet fraction and megakaryocytic hyperplasia on the bone marrow. All these are classic features of immune thrombocytopenic purpura in the absence of other causes. So to end, I would like to say that there are two investigations which are game changers in diagnosis of thrombocytopenia. One is the immature platelet fraction and second is the bone marrow examination. For more hematological insights, please follow this channel. Thank you.